Hi, it's Charlie Lees here, and these are key initial findings from the CLARITY IBD study, which I'm putting into context for COVID and IBD and other immune-mediated diseases. Here are my key disclosures. And this is the current cumulative death rate per million people of COVID-19 across the world, where tragically nearly 3 million people have died from this new disease. And unfortunately, it's not over yet. Whilst we're seeing improvements in some parts of the world, across Europe and South America in particular, we're seeing a very significant surge of new cases, in part driven by some of the new variants of the SARS-CoV-2 virus. Very worryingly, in Brazil, the death rate is going up almost exponentially, but across much of Europe, there is great cause for concern at the moment. In the UK, we've already had a very bad winter where the B117 variant, or the Kent variant, drove cases, hospitalizations to almost breaking point for the NHS, and unfortunately the death rate went very high. Thankfully, this is coming down very sharply, mostly thanks to a very strict lockdown, but also thanks to an early rapid vaccination rollout that was designed to prevent deaths from COVID. What is the biggest risk factor from dying from COVID? Well, it's being old, and it's also being male. We can look further into the data, and we can see that it's also associated with a number of comorbidities, notably diabetes, hypertension, lung disease, also being overweight and obese. It's associated with non-white ethnicity. A number of data sets have shown association with steroids, equating to a prednisolone dose of 20 milligrams or more per day. The jury is out about other immunosuppression medications. Rituximab for rheumatoid arthritis appears to be a risk. Anti-TNF therapy does not appear to be a risk and may in fact be protective against severe disease. We still don't have enough data points really to understand about the risk of thiopurines and methotrexate. A year ago, we did our very best to produce guidance about who was at highest risk, patients with inflammatory bowel disease on different medications with different disease phenotypes and different medications to justify who should be shielded versus not. And you'll be familiar now with the risk grid that we put together for that. Over 35,000 patients have accessed the UK IBD registry risk tool that Nick Kennedy generated, and that's allowed patients to work out what risk grouping they were in. Okay, let's move to talk about vaccines now. We have 6 different vaccines that have been shown to be very effective against COVID-19 disease. All prevent severe COVID and death. All are effective and all have been shown to be safe. These are the adenovirus vector vaccines, the mRNA vaccines, and the protein subunit vaccines. In the UK, we have the Joint Committee on Vaccinations and Immunisations, or JCVI, that produces recommendations on vaccine and immunisation strategies. At the very end of 2020, they very strongly advised that delivery of the first dose of vaccine to as many eligible patients as possible should be prioritised over the second dose. And then we saw this strategy whereby the second dose would be delayed up to a maximum of 12 weeks after the first dose. Recently, some other countries have followed this strategy. Let's look at the IBD guidelines. These are the IOIBD, the International Organization for IBD Guidelines, published in Gut. They stipulate very simply, patients with IBD should be vaccinated against COVID. The best time to vaccinate is at the earliest opportunity to do so, and vaccination should not be deferred because a patient is on immunosuppressants. To which we can add, patients should not stop or withhold their immunosuppressant medications to get vaccinated against COVID. The BSG and Crohn's and colitis UK guidelines that we produced have similar recommendations. We strongly support COVID vaccination for patients with IBD. The risk of COVID vaccination in patients with IBD are anticipated to be very low. And importantly, in patients taking immunosuppressive drugs, the key concerns relate to theoretical risks of suboptimal vaccine responses. Well, why did we say that last point? We said that because in IBD, patients on thiopurines and patients on anti-TNF therapy have previously been shown to have slightly lower immune responses to vaccinations against influenza, hepatitis B, and pneumococcus. So we wondered whether or not that might be the same with the COVID-19 vaccines. So that's why Tariq Ahmed in Exeter assembled a team, including Nick Powell at Imperial, his crew in Exeter, Nick Kennedy, James Goodhand, and Claire Bewshea, to investigate this. And Claire masterminded and oversaw this incredible recruitment to the CLARITY study in the last quarter of 2020, where an incredible 7,226 patients were recruited in just 10 weeks leading up to Christmas across 92 different hospitals, requiring 575 healthcare professionals. The study was designed to test the difference between infliximab and vedolizumab. Why? Well, infliximab, designed as an anti-TNF drug that we use very commonly in Crohn's disease and ulcerative colitis, requires patients to come to the hospital for infusions through the vein. Vedolizumab is a gut-selective anti-integrin, which does not hamper immune responses, but also requires patients to come up to the hospital for infusions at roughly the same time intervals, and so would function as a really great control arm to this study. We recruited 2 infliximab patients for every 1 vedolizumab patient, as you can see in the chart here. At baseline, we looked to see what the seroprevalence of antibodies to COVID was across the cohort, and you can see here how this separated by geography. So you can see the lowest rates down in the southwest of England, in Wales and in Scotland, and the highest rates, as had been seen this was in October, November, December last year, so as we had seen in London, the Midlands, and the north of England. So I'm now going to show you the results of the first major CLARITY paper that was published in full in Gut about a week ago. This study aimed to define in patients with IBD whether biological class, concomitant use of an immunomodulator, and or social distancing measures impact seroprevalence of IBD, seroprevalence of SARS-CoV-2, subsequent seroconversion in patients with infection confirmed by prior PCR testing, and the magnitude of anti-SARS-CoV-2 reactivity. The eligibility criteria were very simple: aged 5 years and over, a diagnosis of IBD, and you had to have been on the infliximab or vedolizumab for 6 weeks or more. So first up, we noted that adherence to social distancing measures, and that was in the UK lockdown from April to July 2020, and exposure to COVID-19 cases was similar between infliximab and vedolizumab. Moreover, there were no differences between infliximab and vedolizumab patients who, 1, reported symptoms of suspected COVID-19, 2, tested positive by PCR for SARS-CoV-2, and 3, were hospitalized with confirmed COVID-19. So this showed us that this was indeed a very good experimental design, and that the vedolizumab group was going to be a great comparator to test the impact of anti-TNF therapy with infliximab on the seroprevalence of COVID. In other words, we wanted to work out what the memory response, the immune memory to COVID-19 infection was in patients on anti-TNF therapy with infliximab versus vedolizumab. So we look at that first by looking at the baseline seroprevalence anti-SARS-CoV-2. And you can see, indeed, it is significantly lower in patients on infliximab at 3.4% versus those on vedolizumab. And then when we look at the impact of also being on immunomodulator therapy, that's azathioprine, mercaptopurine, or methotrexate, you can see there is a further impact. So if you're on infliximab and an immune modulator, your seroprevalence was 3%. If you're on infliximab by itself, it's 4.1%. If you're on vedolizumab and immune modulator, it's 4.5%. But if you're on vedolizumab by itself, it's at the highest at 6.3%. Next, we look to work out with a multivariable logistic regression model what the associations there were with a positive anti-SARS-CoV-2 antibody test. And we could see at the top that being on infliximab was negatively associated. You could see that age was negatively associated, but non-white ethnicity was positively associated, as was various geographical locations across the UK, as we could expect from the initial map that I showed you. We next looked at the magnitude of anti-SARS-CoV-2 reactivity over time following a positive PCR test. So these are just the patients who had a confirmed PCR test before entering the study showing that they had had COVID-19. And you can see that in orange, the patients on infliximab, after about 4 weeks, have high antibody levels against SARS-CoV-2, whereas those in infliximab in the green, it doesn't shift, it stays low, suggesting that the immune response to the virus is attenuated. We're going to look at this slightly differently now. This is seroconversion in IBD cases with confirmed SARS-CoV-2 infection. In other words, what's the percentage, what's the number of patients who have confirmed COVID-19 by PCR who go on to have a detectable antibody? So if you look at vedolizumab overall, it's very high, it's about 83%. If you look at infliximab overall, it's much lower, it's 48%. And then you can see here really clearly the impact of being on an immune modulator or not. If you're not, it's 60%, whereas if you are, so infliximab plus an immune modulator, it's down at 37%. So the summary of these findings are infliximab patients have attenuated serological responses to SARS-CoV-2 infection with lower seroprevalence, seroconversion, and antibody reactivity. There are similar rates of symptomatic and proven SARS-CoV-2 infection between infliximab and vedolizumab. These suggest that the findings cannot be explained by differences in acquisition or severity of infection alone, and concomitant immunomodulatory therapy with thiopurines or methotrexate further blunts the serological response to both drugs. Now, it's really important to emphasize at this point that this in no way has translated into worse outcomes. And in fact, as I said at the start, it does seem from the data that's emerging that if you're on an anti-TNF therapy, that your chances of getting severe COVID outcomes may be lower. You may actually be protected from the severe outcomes from being on the drug. However, it doesn't look like you mount a particularly good memory to the infection if you're on these drugs, having had it by natural infection itself. So the next question was, what about the impact of vaccination? So these data were just released today. These are released on medRxiv. This is a preprint. So this means that these data have not yet been through formal peer review, although they have been submitted over the weekend for a formal peer review process. So here the objectives were to define in patients with IBD who had received a COVID-19 vaccination whether biologic class and concomitant use of an immune modulator impact anti-SARS-CoV-2 spike antibody levels. So this is antibodies against the spike protein, which is the bit of COVID or the bit of the SARS-CoV-2 virus that the vaccines are using to mount immune memory to. So this spike antibody is the bit that tells you if you've been vaccinated, as opposed to the main antibody level that looks at the impact of COVID disease itself. So the impact on antibody levels, the impact on seroconversion rates, and the impact on antibody responses in patients who have been previously infected with SARS-CoV-2 or who have had 2 doses of the vaccine. Split onto 2 pages are the demographics, the phenotypes, and the drug disposition of the 2 groups. What we did here was we did the study once we had in the lab in Exeter the Roche anti-spike antibody assay available, set up and running. And at this point, we had the numbers that you can see here on infliximab, 865, who had had 1 dose of vaccine, and on vedolizumab, 428, who had had 1 dose of vaccine. And very neatly, you can see that it was very roughly evenly split between the 2 different vaccines. That's the Pfizer Biontech vaccine and the Oxford AstraZeneca vaccine. You can see that the patients on infliximab were slightly younger than those on vedolizumab, as you might expect. The ethnicity was much the same. The Crohn's disease was slightly more common in infliximab, whereas vedolizumab patients were more likely to have ulcerative colitis, a roughly similar duration of IBD, and a younger age at diagnosis with infliximab, again, as we might expect. More patients with infliximab were on an immune modulator. More patients with vedolizumab were on a 5-ASA. Steroid use was slightly higher on vedolizumab. BMI was roughly the same. Comorbidity slightly higher, as we would expect, on vedolizumab. And active disease slightly higher again in patients treated with vedolizumab. So this is the key initial result. This chart shows you here on the left the Pfizer Biontech vaccine and on the right the Oxford AstraZeneca vaccine. And the results between the two vaccines look very similar indeed. In the green, you can see patients in infliximab, and in orange, you can see patients on vedolizumab. And what you're looking at here is the anti-spike antibody levels, and you can see that they are lower in both vaccines in patients on infliximab versus vedolizumab. So on the left here, Pfizer-BioNTech, and on the right here with the Oxford AstraZeneca vaccine. This blue line across the middle is 15. This is the cutoff that the manufacturer, Roche, say is associated with protection against COVID. This is the key cutoff that looks to be relevant based on the in vitro assays. We then looked to see what factors were associated with a fold change in spike antibody concentration. And this is split into three panels. On the top, the Pfizer-BioNTech, in the middle, the Oxford AstraZeneca. And because the pattern here looks very similar, the variables are the same, we can then look at the bottom, which is the two combined. And you can see here that infliximab versus vedolizumab has a very much lower fold change. You can see same with an immune modulator, azathioprine, mercaptan, or methotrexate. Crohn's disease versus ulcerative colitis, you can see, and age, older age, as well as smoking. Whereas interestingly, non-white ethnicity was associated with non-white ethnicity was actually associated with increasing spike antibody concentrations. This next chart shows the rolling mean of spike antibody concentrations over time. You can see on the left here, this is for the Pfizer-BioNTech vaccine, that actually it looks pretty similar for the first couple of weeks, and then it separates clearly out. So if you're on vedolizumab, it goes up and up and up, and then stabilizes, whereas this doesn't happen if you're on infliximab. And this is very much the same as what you see on the right-hand panel here for the Oxford AstraZeneca vaccine. This chart shows the percentage of patients who seroconvert. So this means that once you've had one dose of vaccine, your anti-spike antibodies go above 15. And again, on the left, we've got the Pfizer-BioNTech vaccine, and on the right, we've got the Oxford Astra vaccine. And the order's the same for each. So your highest rates of seroconversion are if you're on vedolizumab without being on immune modulator, and that's for both the vaccines. The lowest is if you are on infliximab and an immune modulator, within between infliximab by itself and vedolizumab by itself. Okay, so far this may look a bit doom and gloom, but actually this is a good news story, because partly we had anticipated that this might be the case. What appears to be the good news is that if you have two exposures to COVID antigen, you mount a normal immune response. And those two exposures are either prior infection with SARS-CoV-2, so prior COVID and one dose of vaccine, or 2 doses of vaccine. So what we can see here on the left in the green is the patients who had no prior COVID and 1 dose of vaccine. And you can see here that the black line, which is the median level, is below this blue threshold of 15. Whereas if you'd had prior infection and get 1 dose, it's very much better, back into the normal ranges, as well as if you've had 2 doses of Pfizer-BioNTech. This is with vedolizumab. You can see that prior infection and 1 dose, you go higher again, and 2 doses, you go higher again, but from a much better starting point. With the Oxford AstraZeneca vaccine, we can see this for prior infection. Here in this third panel across, where with one dose, no prior infection, it's low, but one dose with prior infection, it's high. We don't yet have enough data points for two vaccine doses here, but we anticipate it will be the same as with the Pfizer Biontech vaccine. So what have we shown here? What are the new findings? So anti-SARS-CoV-2 antibody spike, antibody concentration. So these, remember, measure the exposure and memory to the vaccine effect, and the rates of seroconversion were lower with infliximab compared to vedolizumab, and this was following primary vaccination with both Pfizer Biontech and with the Oxford AstraZeneca vaccine. We see lower anti-SARS-CoV-2 antibody concentrations in older age, immune modulatory use, Crohn's disease, and current smoking, but conversely, higher with non-white ethnicity. Higher anti-SARS-CoV-2 antibody concentrations and higher seroconversion rates, firstly with past COVID infection prior to a single dose of either vaccine and after 2 doses of Pfizer-BioNTech vaccine. We expect the same to be the case for the Oxford AstraZeneca vaccine. So actually, in the end, what we're showing is that this is rescued by 2 doses, 2 exposures, either prior infection and 1 vaccine dose or 2 doses of vaccine. So what's the impact? What does this mean and what should we do? So for patients treated with anti-TNF therapy, so infliximab and adalimumab in IBD, but we presume also the other anti-TNFs in rheumatology and dermatology, for example, and in particular those on an immune modulator, poor antibody responses to a single dose of vaccine exposes them to a potential increased risk of SARS-CoV-2 infection. But given that we see this rescue effect, we think that patients on anti-TNF therapy should be prioritized for optimally timed second doses. So in the UK and in other countries where this delayed dosing has been put in place by the JCVI, we believe that this should mean that we should try to arrange for patients on anti-TNF therapy to get the second dose on time. But nonetheless, in the meantime, until patients receive a second vaccine dose, and this is good practice for everyone, I should hasten to add, they should consider they're not protected from SARS-CoV-2 infection and continue to practice enhanced physical distancing and shielding if appropriate. So I'm just going to finish with a UK slant again, because this is where we're most affected with this delayed dosing. Just to show you the cumulative first dose vaccinations across the 4 nations, which have now totaled over 30 million. And importantly, that there are already about 3.5 million people who've had both doses, and this is gearing up very, very quickly indeed. So if you look down the JCVI priority groups, Group 4 and Group 6 that capture the clinically extremely vulnerable and the clinically vulnerable, and that captures all the patients who are impacted here. The expectation is that the second doses should be coming really quite soon, I think at least in the next month or 2. And so I would urge people not to be concerned by these findings, rather to be reassured by what we find overall, to continue to practice social distancing in the meantime, and please to continue taking the medications. That's a really important outcome from me to say to patients, please keep taking your drugs. Finally, Crohn's and Colitis UK are keeping their FAQ up to date. There's already an excellent section on the first Clarity paper with a link here. I'm sure there'll be an update with the second paper very, very soon indeed. That's it for me today. Thank you very much for listening.